Hello and welcome everyone. I'm Leah Mix, CEO of Delphi. On April 18th, President Trump signed the Accelerating Medical Treatments for Serious Mental Illness Executive Order, directing federal agencies to fast-track development and patient access for psychedelic medicines. Very exciting development, and we are blessed and honored to have with us today Dr. Leith States and Ryan Roberts to share their perspective on the executive order, what it means, what it doesn't mean, and help us have some deeper insight as a community into what we can expect to unfold from here and things that might not be the best kind of thinking. So really deep expertise sitting in the room today, and I'm so grateful for each of these human beings and what they have brought to bear to the human cause and specifically to the psychedelic cause. Dr. Leith States is a physician and Navy veteran. He is also the former acting assistant secretary for health at Health and Human Services, where he served as the chief medical officer as well. Dr. States brings the federal health system view into this conversation, how executive orders move through agencies, what implementation actually requires, and where psychedelic medicine fits into a broader public health, veteran health, and evidence development priorities. And it's been such a pleasure to have the opportunity to work with Dr. States over the years and to have him as a member of our board for the Ibogaine Healthcare Policy Institute. Thank you for being here, Dr. States. Ryan Roberts is a Marine Corps combat veteran and policy advocate whose work has focused on expanding responsible access to psychedelic therapies for veterans and others with severe trauma, addiction, and brain injury, and specifically focusing on moral injury. It's a very niche and important area of expertise that Ryan has. It was closely involved in the Texas Ibogaine policy effort, which has become one of the most important state-level examples of how veteran advocacy, research infrastructure, and public policy can come together. And we are very delighted, Ryan, to have you involved in the Ibogaine Healthcare Policy Institute as well, and to be a Delphi advisor. So welcome to you both.
Thank you, Leah. Happy to be here.
Yeah. So I'm just going to give a very quick overview. I think most of our audience will be familiar with this executive order by now. And really the purpose of our conversation is to take the discussion a layer deeper and hear from your perspectives, which are deeply informed by your experiences, your professional experiences, your personal experiences, about what this executive order means. As most of us know, the order has 5 provisions. There's an FDA priority voucher, which accelerates the review time for breakthrough psychedelic therapies that have breakthrough designation. Of course, that's still within the FDA's purview to decide which ones, and we've already seen 3 of those vouchers to be issued, which may be part of our conversation today. It also establishes the right to try pathway and directing the FDA and DEA to actually create a right to try pathway for eligible patients, which undoes some case law that had gone in the other direction. This executive order actually says, no, we need a right to try pathway to be established. There is a federal state matching funds that are authorized here. It's not new appropriations, it's existing ARPA-H money, but it's $50 million that is to be used to match state funds that are being put in, such as the $50 million that was put in by the state of Texas. There is an interagency data sharing provision, which requires formal data sharing between HHS, FDA, the VA, and the private sector, which can then feed into the clinical evidence pipeline for the FDA's evaluation. And then finally, there is a timely rescheduling pathway, which directs the Attorney General and DEA to actually begin the rescheduling process once a psychedelic successfully completes phase 3 trials. So that's all good news. That's all sounds like acceleration. There's some key things, of course, that it does not do, which we will allow you guys to elaborate on, but it does not legalize. I think it's important for safety to say that it does not legalize or reschedule psychedelics. It doesn't, again, create any new appropriations. But these five concrete mechanisms could be very meaningful to the field. We'll get into these. There's some other things that it doesn't do. It doesn't change the FDA's standards for approval. Basically, it still keeps the agencies, all of their authority still resides within the agencies to make the decisions that they might do. If they change their standards, that's up to the FDA. It doesn't address the domestic supply chain issue for Ibogaine, and it doesn't address things like insurance coverage or reimbursement or clinical delivery infrastructure, which are pretty much downstream from here. So that is just a very general recap. But I'd like to really turn this over to each of you. And this is a question for both of you. I'd really love to hear, and I know the audience would love to hear each of your perspective on what this executive order actually means in practical terms for the field of psychedelics and for the future of access to these treatments. And importantly, where helpful, what doesn't it mean? And whoever feels called to start is welcome.
I'm happy to jump in and take a first swipe at it. So again, thank you, Leah. Thank you to Delphi for the invitation to come speak. And Ryan, always nice to see you and be sharing the stage with you here. This is a really nice compliment in terms of our background and experience. So from my perspective on what the EO is, and maybe I'll give a quick bit of context. So my background in former roles in the government space was at senior headquarters level of HHS, where we received a constant flow of executive orders, right? And this is where I will say that multiple things can be true at the same time. So I'm going to hold multiple things equal. An EO is worth the paper it's written on, but an EO is also a very important permissive signal to the agencies, to executive offices of the president, to the wider infrastructure and landscape, the ecosystem that the EO refers to. And that's one thing in terms of how I would view it. Now, so if we're going to look at maybe three takeaways in terms of what that means, then yes, it's a clear permission structure for the federal government. So as the EO was signed, and as I've continued to engage with my friends from FDA, from VA, from DOD, from even DEA and DOJ, it's permission to maybe allow a more effective and open collaboration between senior political appointees and career staff. That this is an important nuance here. In career staff that's already been doing this work for many years, on the order of over a decade. So it's not as if Joe Rogan and the EO show came in, snapped fingers, and now, oh gosh, we have something on the precipice of approval. That's not the case. So this isn't just going to slam something home without respect for evidence, without respect for the guardrails of public health, public safety, public good, and at the expense of parity with other drug candidates. It doesn't do that. This class of drugs will still be considered with the same rigor and the same level of quality requirement and safety that any other drug candidate would be considered. The other great thing I think it does do is we've already seen, I would say that FDA has probably taken the most action in the days since the signing, which I think reflects the work they'd already done and the fact that they'd already been in a bit of a frying pan over the last 10 years or so on this topic area. If we want to look at like the MDMA AdCom, we want to look at the guidance to industry that was put out back in 2023, the draft guidance. If we want to look at the line of breakthrough therapy designation drug candidates that have been put in place since 2017, there's been active work in intention and thoughtful care, albeit tension with the outside world and some of the advocacy groups and the pharma pieces, right? But in that active tension, there's been incremental change and has helped prepare FDA for this moment to be, I would call it almost not a leader of the pack, but doing some really wonderful things to take advantage of the opportunity the EO provides. And I'm sure we'll talk about some of the other federal entities as well. And then it's just that window of opportunity. I did mention their EOs are as good as the paper they're written on, but they're also worth their weight in gold in as much as there's been an effective level of preparation and buy-in and setting the table with the folks that are going to be required to execute on this. And from what I can tell, there's been a good level of socialization and folks are taking this opportunity seriously. The worst outcome that could happen is the EO gets signed, but everybody at the agencies has other work to be done and they can just drag their feet. And because it doesn't come with the force of law, it doesn't come with money, it doesn't come within regulatory standards and enforcement requirements, it just becomes another thing that doesn't have to be done. But I don't think that will be the case in most dimensions of the EO. I do think there are areas that are not going to be acted on, and we'll talk about that, I'm sure. I'll stop there and defer to Ryan, see if he has any complementary thoughts. But that's my little, in a nutshell.
Yeah, no, that's wonderful, Leith, and I appreciate you setting that up. Obviously, you have that clear line of sight given your experience, and I agree. I think, maybe what I bring to the table will be complementary, and hopefully will give the audience maybe a more well-rounded view. Somebody may be wondering, what does this mean for the veteran community, this community that was cited over and over again, and the suicide epidemic that's ravaging the community? And hopefully I can add a little bit to that. And definitely don't want to assume that I'm speaking for the veteran community as a whole, because I think in the wake of this executive order, we've seen a lot of different opinions come out of the veteran community from really all across the landscape, who were very much in support of it, some who were supportive but cautious, and then some who don't think it's that worthy of all the praise and recognition that it's getting. And I guess maybe I'll share just a snippet of my background, because I think it helps understand how my perspective is formed. So beyond being a combat veteran who came home to search for answers in a system that was excellent when it came to stabilizing some of the symptomology I faced, that helped regulate a lot of the challenges I was having, but could never really get me across that finish line towards that feeling of wholeness and completeness again. And through our community, found my way to Ibogaine assisted therapy, and that just catalyzed a healing journey that I'm very much still on to this day. And I think it just speaks to, I think, these psychedelics being viewed as these catalysts, right? Not as, there's not this magic pill. And I think that really comes into play when we talk about the landscape that these medicines need to exist in, that is in many ways different from the current structure, the way the current medical paradigm operates. Because I also spent a great amount of time in there, almost 2 decades, working in traditional Western medicine, from primary care up to senior executive roles in academic medicine, in clinical research, and working in oncology. So my perspective spans both those, as well as what Leah noted, being a founding member of the Veteran Mental Health Leadership Coalition, where I've been alongside so many amazing veterans and those in support of veterans to move these medicines forward, and absolutely played a role in paving the way for this EO to be a realization. So I would say from the EO, and as things have settled and I've reflected on it, I think, as you spoke to, Leith, what it does, I think it does well. I'm always looking for signal, right? And I think it does move that federal posture on a class of compounds that have been basically stuck in the mud for at least 50 years now. And what it's done is it's opened that regulatory layer that's opened. And I don't want to discount that. I think that's real and that's significant. But I think the harder question, the one that I sit with, is what the EO is not. And Leah, you were definitely alluding to this, and we will absolutely get into what it's not. And I would second what Leith said. It's not a finish line, right? This is not an access guarantee in any way. But if you're looking at this as a race, it's speeding the race up. It's not moving the starting line, and it's not moving the finishing line. But it is greasing the wheels of a process that has been very slow. And we know the statistics. Every day that passes, we have 17.5 on a conservative level deaths in the veteran community, not to mention the suicides that exist in the civilian population. So time is never in our favor. And what this isn't is not, as a veteran, if you're in crisis, this is not now, oh, I wake up the next day and there's this clear path to care. Right? Again, it is really just an accelerated process, but the race is still there to run. And I think there are layers to this. Regulatory is the one we spoke to, and Leith, maybe you'll go into a little bit more of the mechanics if we need to, but the EO absolutely opens up that layer. Right? The second is that operational layer, right? Before the EO, that binding constraint was that federal review process, was sitting with the FDA, was moving it into that IND process and then into the clinical research process. But the EO just moved that bottleneck downstream, as Leah was speaking to. Now we're looking at, what about the workforce? What about the facilities? What about the payer coverage? What do we do about this model of preparation, integration, and these long 6 to 8 hour sessions, right? Those are now the things we need to start thinking about. And I think it's not included in the EO. Part of it is because the EO authority goes so far. But I think all of it, it's also, I think, looking at kind of a federalist view of let's let the state and all of the bodies who are responsible for deciding those pieces work on those pieces, and the federal government will do what it can on its part. And then I think that third part is probably most missed is the question of whether, I think it's paradigmatic in a lot of ways, right? We're working inside something that's largely insufficient for what these compounds actually offer, right? They sit at this seam between body, mind, spirit, and community. We hear this a lot with veterans moving through the medicine. Yes, absolutely. It helped with the symptomology and what I was facing, but it also worked on all of these other things that maybe I wasn't prepared for or I didn't know how to handle once I got home. And the clinical paradigm catches part of that picture, but it doesn't catch all of it, right? Not everything that veterans are up against is pathology. And that's not failure of the paradigm. I think boundary conditions are there for a real reason. Boundary conditions allow for depth and precision and meaningful work to happen. And as long as we understand that the clinical container can catch part of it, we need to find a way to maybe not bolt on, but create seams between this paradigm and a paradigm of community support as well, because it's really what this medicine demands and something that no executive order is going to solve. But the acceleration on the regulatory piece is real. The operational gaps are there. And there's that deeper question for me that whether this paradigm can really hold these compounds, hold these layers. And I think we're going to get into that in our conversation.
So many incredibly important points that you both have made. And I just want to take something, Ryan, that you've talked about and then step back, Leith, to some things that you're saying. Another way of looking at this is where we might have felt like we had some more spaciousness in terms of the implementation piece on the far end with training, workforce development, integration into the healthcare system with all of these components needed. That's actually now perhaps a little bit more compressed. We perhaps have less time. And as the awareness around things like ibogaine become even greater from the executive order, the demand increases as well. So now we're in a higher pressure situation where we really need to keep focused. We really need to keep the eye on the prize. And Leith, back to what you were saying about there's a standard non-enforcement clause in this executive order, which means that it really puts it on the agencies themselves and the staff within the agencies to drive forward or not. And you alluded to a sense that while it gives the existing staff more leeway, that there are going to be some areas possibly of drag. And so could you speak a little bit to where you expect to see acceleration that is encouraged by the executive order and where you expect there to still be some stickiness?
That's well said. So I appreciate the reflection, spot on. And the way I might cut that is that each agency has their own culture, their own approach to work, their own set of right and left lateral limits that really keep them within the container and how they see the world. The biggest contrast here is going to be FDA and the DEA. So let me be very careful about that because I have a lot of wonderful colleagues at DEA and Department of Justice, but they view their role through the CSA, through the Controlled Substances Act, right? And they have a outsized and I think perhaps appropriate interest at points in terms of retaining positive control over all situations around substances, okay? The specific one that we're going to call out right now is Schedule 1, especially as it relates to right to try. And the reason I'm calling that out, obviously, is because it was contained within the executive order as a line item to be worked on. For a bit of quick background, folks might remember right to try as an initiative, piece of legislation that was put through during the first Trump administration, with the idea being for medications, drug candidates that maybe had a great level of evidence, weren't quite approved, but there was an opportunity to maybe increase access to populations that otherwise wouldn't receive them during the clinical trials phase, meaning folks that were actually really sick, that had more than just one diagnosis, that had comorbid conditions, that otherwise would be excluded from the rigor of a clinical trial protocol. This was meant to fill that gap. The two important caveats there. One, this would be at the discretion of the sponsor, so at the discretion of the drug company, because that is a voluntary program for them to engage in. The secondary piece here and why to try didn't really realize its full promise, especially as it relates to this class of drug candidates, is it didn't address the gap in the Controlled Substances Act for Schedule I drug candidates without currently accepted medical use. So all of these drug candidates right now that are in Schedule I, whether that's psilocybin, LSD, a variety of others, even though we might have really strong phase 2, phase 3 data, or even just phase 1 data with unmet need, good safety data, a sponsor that wanted to provide that to patients that otherwise don't meet criteria for a clinical trial wouldn't be able to receive that medication or that candidate because the DEA doesn't have the positive control in place through a special registration pathway to monitor the dispensing, the administration, and the safety on the back end for diversion control, all the things that DEA does. I'm bringing up all those little nitpicky things because that's the actual operational and execution piece, the tactical pieces of taking an EO from just a wonderful piece of paper and a signature and photo op to something that actually impacts patients now. So the example I'll give in terms of where we're working well to actually meet the rubber where the road is the Freedom to Heal Act. And that actually is something that's been put in place. Actually, VMHLC Reason for Hope has been helping push this piece of legislation through. And it creates that special registration pathway for DEA that would fill that gap that's not readily recognized or discussed in the executive order. But it is the lowest hanging piece of fruit that actually answers the call and could give us a checkbox, one, for these drug candidates now, to help patients now, even though, to Ryan's original point, we're looking at probably a very long time horizon for a lot of these to get through an approved medicine pathway and actually become FDA approved. So that's one example where FDA isn't even involved in that one, but that's going to be predicated on DEA. And because there's already been a significant amount of input provided by DEA in terms of what would be needed from their standpoint to be successful, I think that one has a very good chance of going forward. That said, the other example, the rescheduling pathway in terms of the actual timeline, encouraging DEA to start the reschedule with phase 3 submission or with phase 3 completion as opposed to actual drug approval. There's nothing there pushing them from a regulatory piece. There's nothing there to say you have to do this. It says, could you please try to do this? And I don't get the sense, and others have chimed in as well, that's going to be the case. So I still would anticipate some foot dragging because it's not going to be clear to DEA that that's going to be a useful, beneficial exercise that retains their posture in fulfilling their CSA requirements. Outside of other political changes, that's just an area where I think you have that variable speed and then hesitation. With VA, just giving one more example in terms of kind of the other players at the table, to VA's wonderful credit, they have had an integrated planning team in place for psychedelics since 2023. Myself and a couple other members from HHS, we were very fortunate to be honorary members of that IPT and have seen firsthand the wonderful and intentional work that they've been doing, one, through clinical trials at 9 different sites and attempting to expand that clinical trial footprint. They've also worked towards the right strategic partnerships, workforce development, education and training, implementation science, working towards socializing this in a thoughtful and intentional way with career staff and political appointees, and doing the great work of taking the lumps from Congress and providing hearings and testimony, and just being that constant presence of the VA is a complicated beast. They don't do everything well, but they are working on this intentionally and trying to move forward at the right rate that respects the opportunity for veterans, but also respects the constraints and the needs to do this in a thoughtful way. So that just gets back to this EO provides a window of opportunity and allows them to hit the gas pedal more fully with VA secretary permission and oversight, as opposed to trying to do things on their own in the shadows.
Hear you, Leith, in that it's a matter, maybe we can say, of the culture inside of these agencies and the infrastructure and the existing work that's been done, as you say, that will have an effect on what moves quickly and where there's drag and where there's rub. and you've called out some really specific areas. It's super helpful. And the note about legislation. So that's something that's not really being talked about. I think we need to lay that on the table. The legislation is still needed. The executive order can't do appropriations. It can't do a lot of the things that need to be mandated through Congress. So we still have legislation on the table that still needs to move. That hasn't changed.
Yeah, and I would just add that as we're looking at this, and again, I'm looking at this through the implementation science lens of it, is finding meaningful and thoughtful ways to bring that shared perspective around the problem. Because as you noted, the language is different. The mental models, the way they look at the problem and the path they take to solving problems looks different. Having that systems level capability to look at the entire range of these different organizations and different departments within organizations working towards a shared goal. How do we make sure things are aligned and we're working hopefully in a good partnership with shared language and with shared goals and objectives?
Absolutely. We're going to shift to Q&A. I just want to give you each one opportunity before we do that to say anything else that you'd just like to maybe get off your chest, anything that you feel like really needs to be said or that is burning for you that the audience should hear about this executive order.
Yeah, I'm happy to share what's top of mind for me. And again, I'm here to share a bit from the veterans perspective. And as far as the EO, I think it's going to be a mixed bag for, is this going to meaningfully change anything in a relatively short time? I think if you're a veteran who's maybe engaged or in and around a major academic medical center where you'll have access to these phase 3 trials or emerging trials that are going to be here in the near future, that there's a likelihood. And again, that means you're also a veteran who fits cleanly into what's necessary to be a good quality candidate for a clinical trial, which for veterans with complex comorbidities and a challenging situation that doesn't end with pathology, that's going to be a sliver, right? It's probably not that population who this seeks to serve at the end of the day. Of course, we want to help as many as possible. But when we're looking at those real high risk individuals, they're not going to meet the trial requirements. And we see this reflected in the fact that the VA has lots of trials out there and available, and they've been doing work in that realm for a while, but we still see 5,000 veterans a year traveling to Mexico to get treatment that's not available here because they're not eligible for those trials. So again, what the EO does well, it does well, but it really doesn't for many of the veterans who are in that category where suicidality and suicidal ideation is a real pressing problem for them. It's not changing anything in the near term, but that doesn't mean we need to let off the gas, and it doesn't mean we need to work towards a more long-term solution, because we absolutely do. I think the real work starts now, because if summer is a true deadline where things are going to be out there and available, we do need to fill in all of those incredibly challenging to fill gaps. And every state is going to be different. Their makeup is going to be different. We've seen them have different approaches to the medicine from New Mexico to Texas and beyond. And some are federally aligned, some aren't, and that matters for funding. I think we've got a complex set of opportunities to seize and problems to answer. But I think this is a good signal. It's putting us in the right direction. We just can't forget all of the other pathways to this medicine as well.
Thank you so much, Ryan. Yeah, I think that's a great place to transition. It was super well said in terms of holding the different tensions and keeping the eye on the prize for access to these medicines for those who need the most. So thank you for that. We're going to open it up to audience questions. We have some great questions, wonderful contributors to the field. First is Kate Reynolds, who's with Rocky Mountain Poison Drug Services. If this accelerates the race to approval, could there be a new energy to leverage existing real-world evidence to help ensure successful healthcare system integration? We know that it takes many years, like 14 plus often, for medicine to be fully integrated. Great question from exactly the right person. What would you guys say to that?
So I'll jump in. I appreciate the question. It's absolutely wonderful, spot on, timely. And it alludes to one part of the EO, where that collaboration piece, the data piece. And I want to come back to the existing pipeline of relationships and agreements and data sharing that was already happening, because there are already a variety of DUAs, MOUs, MOAs between VA and HHS with regards to data share, right? So it could be around facilitating clinical trials data, but also specifically that real world evidence piece where it gets to some of the implementation, harm reduction, and just public health protections, and then optimizing care delivery. This absolutely should be advancing that, should be bolstering that. And I don't see a pathway where that does not happen. And the reason I say that is that the way that this is going to be stress test, the proving ground will be VHA. And VHA is our capture on universal healthcare, soup to nuts, EHR, not just encounter data, but also some of the ancillary things that can be used to build that real world evidence power. And something we've seen from the FDA over the last year plus with this new administration is a leaning back towards real world evidence, reformatting, reframing their entire approach to it. And in terms of institutional incremental change that gets away from just stagnated bureaucracy, I think it is timely, and it's going to be done in a way that actually makes sense with a value add, as opposed to just standing up a program within an institution that only silos itself, either in the agency or across the center or within centers, which is what the real world evidence program did in FDA previously. So there are a few things that have come together, I think, that add up into a good perfect storm of confluence that's going to allow just what you said, Kate, to flourish with this as a use case.
I would add that one of the maybe positive features of the way we see these different states approaching the way that they're intending to work with these medicines, between the differences with Colorado and Oregon versus, right, where you've got the federally aligned consortium model. And then you have states like Tennessee with their model where they're hopping into a consortium. My hope, and it sounds with Leith's experience, he's alluding to this, is absolutely the case. We're treating all of these different states as a living laboratory where we're able to pull this real world data. And I know in just reading a recent article, Jonathan Dickinson, co-founder MVO, had noted that they did reach out to him for data surrounding ibogaine and what they've been seeing in the clinic. So it sounds like there's very much openness to looking to the places where this is already happening, and maybe it's been happening for some time, especially when we get to some of these more complex medicines like ibogaine. It's going to be especially challenging for a multitude of reasons, not just the molecule itself, but everything to support that molecule. It's just complex in nature. So hopefully we're able to absorb as much learning as we possibly can for those who are already entrenched in this, and could potentially solve the problems that we're going to face as a country in unique ways. Because again, much of this will land on the states to decide. And the federal government, to me, has given a signal that for much of it, it seems like they're going to allow states, probably within some guardrails, but to be able to operate in a model that makes the most sense. We'll see if things move federally to a point where there's a dial back on that. I don't know. But again, I think what you're hinting to is so critical, because with the speed necessary, if summer is a true deadline, to even reach a population like treatment-resistant depression, these things absolutely do not happen overnight. They happen over the course of iterations over time, and that requires real-world practice to iterate.
Thank you both so much. We have quite a few very good questions. Tony Colson. Hi, Tony. Great to have you here, former DEA official. Tony's asking around the right to try. Besides the DEA not providing you see a pathway to the practitioner, there still remains trepidation by a sponsor that there's going to be adverse outcomes. And is there a way to create immunity for the sponsor?
Short answer, no. So it's a voluntary program. It's their risk. There's not indemnification here. If they want to participate, they can, but it's at the risk of creating severe adverse event data, which they certainly don't want going into their drug approval. So that is the trade-off.
Yeah, exactly. And how do you see the medical pathways for patented products impacting the states with regulated programs using natural medicines?
Ryan alluded to, there's going to be this balance of approved medicine pathway and state efforts with ballot and legislative initiatives for natural medicines, whether that's mushrooms, cannabis flower, whatever the case may be. That's going to be in tension. And I would say that the approved medicine pathway is going to have the least amount of folks that are going to be eligible for a variety of reasons. Access constraints due to cost, due to stigma, whatever the case may be. That potentially regulated market that is natural in nature, that's administered by a state, is probably going to be something we need to be considering very fully. So I see that it's going to be difficult. It's one of the things that the EO does not address at all. It does not mention the state experience through that, and it doesn't mention the international implications, things like the Goya Protocol, as you're alluding to, Leah. So there's a lot of real messy tension that it does not speak to, and these will be problematic, not just for public health and public safety, but for the legal challenges that are subsequent.
Great. Thank you, Leith. So this is from Michael Fretkin. Michael, he was a member of the board of psychedelic medicine and therapies, which was intended to be a certification board for psychedelic practitioners. That effort failed to establish a structure that could create accountability and vet psychedelic facilitators, essentially a consumer protection entity. How important do you think this is, and where do you think this work might emerge?
I would say it's paramount. Everything about ethics and patient safety protections, and we've seen some very concerning events south of the border in terms of cutting corners and maybe not being adherent to that regulated, constrained model that has professional expectations and then self-policing of institutions. So I absolutely agree that there needs to be a variety, probably a variety of entities, since the therapists are operating across a series of disciplines. So it's not just doctors, it's not just therapists, it's not just lay individuals that have some peer support back. There's going to be a tiered place. So we need some standard that allows it to be promulgated across the specialty and licensing community, where we've seen some folks or some bodies be very reticent to jump into the fight. The APAs, for example, the psychiatry and psychology, there are other groups that have maybe done a little bit of more chiming in terms of the importance of. And I think there's some fledgling organizations that have attempted to do that in the past, but it's not really borne out, to your point, Michael. So I agree it's going to be absolutely necessary.
I would just reiterate the end goal, that end state is safe and effective access to life-saving therapies. That does not exist without that being taken into account for all the reasons that Leith stated. And anything, I'm sure we could go on and on about that, but critical.
Thank you both so much. I think we have yet to see where in the field the appetite to reapproach that will be generated from, but it sounds like the need still very much exists. So thanks for clarifying that. And thank you for the question, Michael. Last, we have Lori. Lori, thanks for being here. What role will the private sector play? How will the various agencies work with outside entities to push clinical trials and data sharing? So a little bit deeper, how does it actually work?
These are not minute-long questions, Leah. So maybe I can pull out one example and then maybe expand offline at points. The example of the VA, I'll just come to that because that's the place where the proving ground is happening. So in terms of VA collaborations, I think that there's going to be a number of very important touch points across not just clinical research, but education and training, workforce development, and ultimately patient protection and implementation science, where we're already seeing, whether it's the VA nonprofits that have been the cash cow, along with academic centers funding existing clinical trials for psychedelic research within VAs, or we have groups like Sunstone Therapies, where I'm part of right now, where we're working towards kind of collaboration around what would it look like for education and training with one of the trials that we're engaged in, which is with the state of Illinois, and working towards training 200 therapists and treating 200 patients. And how do you do this well and under the conditions of not just clinical trial expectations, but then generating the data for implementation science? One, because it's an important thing to do and a necessary thing to do, but two, to Ryan's point around that truncated timeline now, where if we have the voucher program pushing up the approvals, potentially if there's a shorter time for not the quality of the review, but the duration of the review. But then also, if we do end up with the DEA shortening that reschedule window, the VA will be in a position where they're expected to roll things out probably at a few pilot sites sooner rather than later. If anything, the private sector is going to have to be filling that gap because the funding isn't catching up from the federal government yet. With the budget considerations, we'd probably be looking at FY28 for actual increases in appropriations for VA in their medical services budget to cover expanded services and rollout. That's where private sector comes in and is so important to come alongside during that time of need and this acute rollout where we can do a lot of good to protect the populations we're endeavoring to serve, specifically within the VA. Obviously, that's veterans, but that gets into other considerations around the safety net, FQHCs, CCBHCs, where people are at the highest levels of trauma, suicide, and other types of cases that have come together and creates a lot of need in those populations. That's another place where those strategic partnerships are absolutely necessary.
Thank you so much. And yes, that data sharing provision of the executive order was very helpful, I think, in this regard, and encouraging private sector participation and use of that data. Thank you guys so much. I just want to acknowledge we have also some really great questions that kind of intersect from Tony Colson and from Elliot Marsai, who are leaders in the field. And it's basically, can we trust this? And can we trust that this isn't just a political tool? And how will this affect actual standards and rigor? And I think we're going to have to wait and see how that plays out. I so appreciate both of you for your time today, for everything that you are giving to this cause, for the just incredible people that you are, and appreciation to our audience. Thanks so much for being here with us. I hope this was very helpful and informative to you, and to our team here at Delphi who helps us host these insight sessions. So wishing you all a wonderful Friday, and I look forward to seeing you again on May 6th when we will have Jonathan Dickinson on our next insight session. Thank you all so much.